In my view, the plaque activity test is ideally suited for several clinical scenarios. The first one being primary prevention as an aid in the interpretation of the standard lipid profile. And in that scenario, the negative predictive value of a low plaque activity test is very reassuring for an individual who otherwise would not have treatment called for based on the lipid profile or other multivariate risk assessments. A low Lp(PLA2) level indicates a confirmation of low risk. Conversely, in the same individual at intermediate risk, a higher level of plaque activity testing can swing a decision towards starting a preventive therapy. The second major group is patients who have statin intolerance. Now, the guidelines are very strong in suggesting the use of moderate and high-intensity statins in lowering LDL cholesterol. That's terrific for patients who can tolerate statins. Approximately a third of patients cannot tolerate statins, and then we have a difficult decision of whether or not we really need to use secondary drugs, including ezetimibe, niacin, fibric acid derivatives, bile acid sequestrants, and omega-3 fatty acids. The plaque activity test helps pinpoint the patient who truly needs efforts with these secondary drugs and also identifies individuals who would not need these drugs based on very low activity level testing. The plaque activity test is responsive to all forms of anti-atherosclerotic treatment. Uniquely as a blood test, it's the only test that's responsive to multimodality treatment for atherosclerosis. The third patient group, I think, where it clearly applies is in patients who have a family history of premature coronary heart disease. In that scenario, the primary prevention scenario, a first-degree relative, a mother, father, brother, or sister, has had a myocardial infarction or a cardiovascular death in a man before age 45 and a woman before age 55. In that scenario, for the patient in front of you, the question is, does family history confer risk in that individual and to what extent? And the plaque activity assay, again, is a powerful tool in primary care assessment, helps the clinician better understand the risks that are conveyed to that individual. And I would add the last category is patients with advanced atherosclerosis. In patients where we do have multiple lines of anti-atherosclerotic therapy going, we've performed cardiac revascularization as an example, and we're in follow-up. The main clinical question in that scenario is, have we done enough? Have we brought risk down to the absolute minimum risk for that individual? The only way to tell that is to use the plaque activity test in addition to the standard lipid profile.